So we're going to take questions now from the audience in a general fashion, but I'll ask them to specify to whom they're going to aim the question unless it's general. So who would like to start? Any questions for evolutionary psychiatry, or have we explained everything? We've got Nikhil. Nikhil Chowdhury. Nikhil, what do you want to ask of whom?
I would like. This is sort of to Marco and also to Daniel.
This is to you, Marco, and to Daniel. Shall we ask Daniel to answer first, and then you, perhaps, and
I think Marco was mentioned first, so let's...
Okay, no, lovely,
Well,
fine.
it's both.
I really don't mind.
Well, I was thinking about psychiatric issues and privilege, right? So I was thinking about when people who are in very good environments, what we think of as favourable, have psychiatric issues. And I think there were two things you both said today which could possibly bear on it, and I wanted to know if people have looked into it. So in terms of the life history, perhaps, you know, if you've got a really slow life history, you're so future orientated that you're perhaps more predisposed to certain types of anxiety, and you're just so stuck in your head and you're almost pathologically non-impulsive. And one thing I'd never heard of, Daniel, that you mentioned was the idea that depression could alter risk-taking. It could create inaction when... Well, actually, you mentioned adverse conditions, but maybe if your conditions are really good, that's a time where you need to be inactive because you don't want to change them. So if you're exposed to opportunity, you should get depressed because you shouldn't have an affair with that lower quality mate, or I don't know. I mean, so I was wondering if there's been any works focusing purely on how we can understand psychiatric issues in very good conditions.
Thanks, Nikhil. I'm glad I didn't have to recapitulate that. So, Marco, could you go first, please?
Okay. Well, that's a very broad question, so let me... So this is what I present is really a very, very broad and simplified picture. So for example, with depression, I mean, again, to the extent that we understand the function of, say, anxiety and depression, there's interesting distinctions within that, and they might map on say risk-taking versus risk avoidance in slightly different ways. The depression and anxiety case is a bit complicated. I would say the general pattern of risk factors for disorder really is tilted towards bad environments, which means it's not just bad experiences like stress, family tensions, and neglect and abuse and stuff like that, but it's also exposure to pathogens. It could be all sorts of environmental stressors that are not necessarily behavioral. Given that, there are some disorders in which the pattern is very consistent, and other disorders which are a bit puzzling from the usual perspective. For example, eating disorders, that's one. If you look at eating disorder as a whole, you still find this broad, bad conditions, high stress, low socioeconomic status is actually a generic risk factor for that. But when you start looking at symptoms a bit more in details, for example, differentiating some types of anorexia from bulimic symptoms and different personality profiles, you see that some of those actually, there's evidence that they occur more in what one would think are better environments, safe, the stable family relationships, high stages. So that doesn't make a lot of sense in the standard perspective, and I think it does in, if you make this distinction here. And same for example, for autistic, so autism spectrum disorders. I didn't make the argument, but my argument basically is you have two big clusters, and one is the one which captures most of the mild versions, where you have more contribution of common genetic variants. There's correlation with autistic traits in other family members, and those again, the epidemiology is a bit confused, but there's again several studies finding that better environments, in socioeconomic perspective, there's a higher prevalence of that kind of ASD. Whereas if you look at severe autism spectrum, which I argue is not really a life history correlate at all, is just basically a deleterious mutations driven or other kind of insults, infections. It's a pure harmful dysfunction. That's pretty strong evidence that follows the it's a more kind of in a way uniform distribution with evidence that low socioeconomic and higher stress and higher risk factors of the standard kind increase the risk of that too. Possibly by routes that are not social, like, again, infection, hygiene, nutrition, and early stress, prenatal stress, and things like that. So I don't know if that answered the question because it was very broad, but I think for some disorders, making sense of the epidemiology really requires to go beyond the one-dimensional generalization that bad environments create mental disorders and actually make finer distinction. I think a life history perspective can actually help in that direction.
Thank you very much. I'll take it to Daniel now to answer part of that.
Well, I won't add much to what Marco said, but another thing you need to bear in mind is that certain things that we think of as very dysfunctional only look dysfunctional from the perspective of a very slow life history that has become normative in our society. And I think impulsivity is a great example where there are plenty of arguments out there to be moderately impulsive and to want to run around a lot is actually a pretty kind of normal and adaptive trait. And it's only from the perspective of a very unusual cultural situation that we're in. It's like, I've worked a lot on early childbearing, and having a baby at 15 is a great idea. You're really fertile. You're biologically ready. you get pregnant much more easily. It's only when, from a perspective of a very slow life history, that people start to say that's weird. Why is anyone doing it? So,
thank you very much. A very good point as to the difference between biologically normal and socially normal. Any further questions? Sorry, George, you were next, and then Mustafa.
So very much in the same terrain, and probably for Riyad and Marco this question. I was fascinated by this idea you had that although biologically we're not meant to live long, perhaps in terms of evolution, we now live long. And obviously psychopathology is increasing, and I'm sure there is more than one ways of explaining this. But it sounds to me as the modern condition of regulation, long-term planning, is abusive to many young children, young people as such. It's a direct cause of psychopathology.
Riyad, would you like to answer first?
Well, the point that I would make has already been made by Daniel, which is that I think that there is a mismatch that is in operation right now. We have an ultra-slow life history environment which has never existed before, where people have to invest intensively for decades before they actually come to reap any of the fruits of their investment. That's never been the case before. So people have had to delay and delay and delay reproduction and to expect the future to be rewarding. Even a modest modicum of fast strategy can actually backfire and lead to a label of mental disorder. Whether it's impulsivity or whether it's early parenthood or whether it's crime of one sort or another. So I think that's an issue that is probably leading to some degree of diagnosis of mental disorder that doesn't exist in previous environments.
Gerard is going to answer the question partly as well here.
No, I just want to confirm the mismatch theory. If you look on tribal societies, they have the puberty 5 years later. So our puberty is 5 years earlier. Our great-grandparents had menarche at about 17, now we have it with 12. So it makes it more complicated because we need the autonomy earlier, but we need a longer education at the same time. And the problem of the long education is that the people don't live on their own. They are dependent on the parents, but they want to have the autonomy after puberty. And as soon as these people work and earn their own money, they have no more suicidal ideas and ideas what is the sense of life. So, yeah, I just confirmed the mismatch theory, and what I observed also in tribal societies, the children from 6 or 7 onwards try to learn all the things adults do, gardening, fishing, hunting, and when they are about 18, they can the things as the adult men do it, and boys hunt and make gardens and are successful in fishing, and doing this and showing this, they're attractive for the other sex.
Mm-hmm. Okay. Can I add one?
Please.
Okay, yeah, just on the, so I basically agree with the idea that, you know, the general idea of mismatch in the sense of pushing for a certain kind of, you know, low impulsivity, just delaying and planning and future, where you might not even reap the rewards. One interesting thing I think is happening is that mismatches, you know, so technology can catch up with some mismatches. So for example, now some traits that you could put in the kind of like extreme slow lane of people who have, you know, personality profiles that push them to basically, for example, delay reproduction to an extent that could have been very maladaptive in the sense to delay reproduction so much that you never reproduce. Okay, well, I wonder to what extent assisted reproduction and reproductive technology is actually, you know, depends how you want to see it, but you're kind of correcting the mismatch to some extent, or also allowing some personality profile that would have been weeded out really by selection because they're too, you know, too future oriented, just too delaying everything, and now you can actually have to have more opportunity to reproduce with technological help. So you wonder if that will be over time a little change in selection, and you will have more of those extreme, let's say, slow life history profiles that used to be really at dead ends up to a point, and now they can actually, you know, reproduce and be representing the next generation. So it's interesting to see how this will play out with technological changes too. So there's a mismatch, but there's also the rebound.
Thank you. Any further questions, or Mustafa? Thank you.
Thanks. My question is to Marco. When we look at the schematic representation of the FST model, there is no cross-section between all 3 models. Is that deliberate?
Sorry.
The Venn schemes do not intersect, all of them, like fast,
right.
distress, and slow. There is no 3-point intersection. Is that deliberate?
Right.
And following that, there are certain psychopathological conditions which may really sweep around your scheme from one side to another, because the spectrum is that wide, or some episodic conditions, for example, mixed episode in bipolar, or dissociative experiences. They may span different schemes. So what do you think about those problems, and also the 3-point intersection?
Right. So it's, you know, so it's a model that does make some kind of strong claims. And if it really is the case that some traits set a trade-off between certain risks and other risks, yeah, you don't expect, I mean, if you allow for an overlap in that, it just becomes completely mushy and confused. So the idea there would be, so just keep in mind that the model is not supposed to link disorders to clusters because of the kind of immediate nature of the symptoms. It's really about the kind of more stable correlates in personality and motivational patterns, developmental patterns like maturation and so forth. So even when you have disorder, let's say, well, mania is interesting. I've actually, the argument I've made is that most, you know, bipolar disorder, again, I would classify it in the fast spectrum just because of the personality correlates and the fact that there's a distinctive, in the manic phase, usually kind of hyperactivation, say mating goals and status competition and dominant behavior and so forth. Then what happens in the depressive phase, it's interesting, but it doesn't necessarily change it to as rich in motivational priorities and developmental priorities. So the argument I would make is when there's an apparent disorder that seems to span the whole spectrum from fast to slow, that's actually an opportunity to look and see if you can draw a meaningful distinction between things that look the same at the symptom level, but have different risk factors, correlates, comorbidity patterns, and so on. So that's what the model does. And then, well, I think it kind of works well reasonably. There's some anomalies. So one anomaly I have not resolved. It's some overlap between autistic, like really early onset, childhood onset schizophrenia and autism that I don't think fit the model very well. And there's not also a ton of data. So there are some anomalies here and there. Bipolar can be, again, little data, but I would argue that there's some cluster of manic symptoms that are really on a background of what one would call like slow life history pattern. It's more correlated, for example, to postpartum mania and things like that. But then again, I'm leaving it very tentative in the current version of the model. I'm not making a strong argument that everything has to fit right now. But the general approach is, the fast versus slow distinction, there should be no meaningful overlap because otherwise the model collapses. The way it's resolved in the model is to look for meaningful subtypes. And of course, you want to validate the subtypes by correlating them to different patterns of behavior, different types of comorbidity, different risk factors, say SES versus stress and so on.
Thank you very much. We've got at least one more question. Could you introduce yourself, please?
Hi, so my name's Tim. I'm a junior doctor in F2, working in Oxford.
Thank you for coming.
I just had a question which kind of pertains to that. So I graduated from medical school not too long ago, and I thank you for everyone for your talks. It's been fascinating, and I just wanted to know how all of this this kind of more symptom-based approach and the approaches that are being talked about here are going to translate to medical education for training our futures doctors, because obviously, although a minority become psychiatrists, 50% or so thereabouts become general practitioners who are seeing these people in primary care. So I just wanted to know anyone who has any input on that. Thank you.
I think that's a great question, and thank you very much for it. I think it will be really interesting to study the kind of cultural evolution of these categories, because actually the researchers behind the DSM and behind nosology in general are often aware of these complexities and only consider these very provisional sort of fluid categories. I think it's the compression in the translation to primary care that kind of ends up reifying them. And so I don't know how you take everything we've talked about and squeeze that into a 10-minute consultation. And I think that the reason that these categories end up exerting more influence on clinical practice than they probably should is not that psychiatrists don't understand the fluidity and complexity of these things. It's that actually, you've got very quick algorithmic diagnosis, you've got limited number of treatment options, and you've got 10 minutes to see someone. So I think it's a great question. I don't really know how we solve that. There's a big there's a big talk of personalized medicine, stratified medicine, all of these things we constantly hear about, but actually how those get, mostly medicine is done by GPs who have got a very small amount of time, and they're dealing someone with their office with very non-specific symptoms, often, general somatic symptoms or fatigue is what they're really presenting with. And how do you advise and support them to do the right thing? And, I think I don't have a good answer, but thank you for raising it.
Could I answer that partly? Because we've been very interested in getting this into the MRC Psych syllabus. And I think there are large problems. There are scientific issues that are misunderstood. There are ethical and also sometimes religious and cultural issues about getting evolution in. People mistake us for social Darwinists or eugenics movement. Then there are the creationists. And then there are what we call the ultra reductionist biologists that think everything is genes. Well, it is at one level, of course. It's all chemicals and genes. We believe there's a material basis, but we don't think that's the only explanation. So we have all these difficulties. And then there's the translation, as you say, at the clinic door. And I think it's work in progress. But I do think there's a whole range of possibilities here which can help us with diagnosis and treatment in a humanistic sense. But it doesn't translate instantly, and in that respect we're more like engineers rather than quick fit mechanics. And the trouble is with general practice, it's quick fit, and you can't expect them to sit down. And Randolph Nesse says there's a wonderful story, and if you'll forgive me for taking a little bit of time, it's his story, not mine. He was going through the Arizona desert, and his air conditioning broke down on his BMW. And he said he went to the first place and they recharged it with the liquid gas, whatever it was. And then 80 miles down the road, it went again. And they said, yes, there's a hole in the tube. And so they replaced the tube. And then that went wrong again in another 100 miles. And the chap said, that's because you've got those types of tubes in the air conditioning. And there was 3 levels of explanation. One was just the loss of coolant, then there was the hole in the tube, and then there's the reason why there was the hole in the tube for that model. And I think what we're doing is we're 2-3 stages back, looking at why it develops the hole in the tube, as well as the model of how the coolant causes cooling. And I think to translate that into a 10-minute interview for somebody that needs the coolant replacing is problematic.
I wouldn't expect them, I guess, to make that kind of formulation because I guess it takes years and years of practice, and I wouldn't be expecting a GP to do that in that time. But the conceptualization seems quite different from saying someone's got appendicitis. It's quite clear what the things are, and the cause is very clear. Cause. There are a lot of things that could cause it, but we know it's appendicitis. So I just mean the conceptualization that the symptom cluster is probably more important than slapping someone with a diagnosis and then referring them on.
We believe in diseases, clearly when they're diseases, when there's a Thomas Sydenham histopathological biochemical primary cause of disease. There's not an argument. What we're saying is we don't want to muddle up defences and distress with disease and assume there's a primary disease pathology. And that doesn't mean we don't treat distress. Now, taking your appendix model, we're saying there is right iliac fossa pain and that it's valid to treat pain as a signal of a disease, but treating the pain alone doesn't cover the disease. And in fact, if you're not careful, just treating the pain without looking to the etiology of the disease, as you know in appendicitis, can cause a lot of problems. So what we're trying to say is it's more inclusive as a model rather than going into a dichotomy. Is this a pain? Is it a disease? Well, it's both.
Can I just briefly, sorry, if you'll just indulge me to add a very small moment. I address what I write as much to society as to doctors, because I think in a sense, for me, what this perspective gives you is a broader public health orientation to understand what the sources in the way we live and the way we structure our societies are of these particular problems. Now, that's not terribly helpful if you're, sort of picking up the pieces, as it were. But, for me, that's, as a community, where do we need to be going? We need to be talking also to politicians, and we need to be interacting with sociologists and town planners and, people who work on environmental pollution and those things.
Exactly.
And I hope today's brought that out a little bit.
The reasons for distress must be discerned, not just the distress.
Yeah, indeed.
And a lot of those are psychological, yes, but why are they psychological? Probably evolution and development. But where does it come from? And it comes from the need socially, and that includes housing, employment, life conditions, toxins in the environment, who knows what. I mean, we could go on about this all day. And unless you change that, and the opportunities for people, and I think that's right, the public health model is probably where this is going to have its most immediate effect.
Thank you.
Any further questions? There's a gentleman over here. One more. I think we've got time for one more. Oh, right. Lovely.
Sorry, my name is Jessica Mott. I'm a general practitioner. So it's just, I guess perhaps by way of a comment, it's been very interesting the whole of today, and thank you so much to all of the speakers. It's particularly challenging working in an environment where I think 30 to 40% of my consultations, and that's true across the board, are dealing with mental health related issues. I think one thing I would say is, my perspective is, and I think that's true of many of my colleagues, is that we're increasingly living in greyer areas where we are looking more at symptoms and not necessarily looking to put diagnoses onto those clusters as symptoms, or requiring that of our speciality colleagues. And whilst there is the challenge of the 10 minutes, I know I consistently and many of my colleagues do overrun, we have the benefit of reviewing patients multiple times over months and years, and sometimes we can then, through various interpersonal discussions with them, with our colleagues, Balint, all sorts of other means, build a broader picture. So I would say, as a maybe slightly unwilling representative of my colleagues, that I think many people would agree with the sort of viewpoints and the broader scopes being cited today.
Thank you.
Thank you.
Thank you very much, and we are absolutely delighted to have a GP in our meeting. Honestly, because we consider ourselves in EPSIG to be cross-disciplinary, cross-specialty. The concepts that are applicable to psychiatry are equally applicable to the rest of medicine, and evolution is a central biological idea that applies to the whole of medicine. So great to have you with us. I think we've run out of time now, and I'm not going to sum up what has been discussed today, because it's been so rich and varied. I'm grateful to all 6 of our speakers, and I'm delighted that the video link from the US has worked perfectly, Marco, and thank you very much for that. It's been actually everything I wished for. The talks have been very rich. Anyone who's interested in evolution will know that we are not here for, or we cannot claim to provide quick answers. But hopefully we can help formulate the right questions. And I think that that's really where the strength of evolution lies. And some of the concepts that if we just take them at face value, we might fall into erroneous thinking, such as thinking that defenses are diseases or that disorders are real entities, when in fact they are shorthand for a variety of different phenomena, some of which are real and some of which are a convenient shorthand. But given that we are biological beings, I don't think that ignoring evolutionary theory, which is the central organizing principle for all biological sciences, will get us very far. So I think that the message is that hopefully we have persuaded some people today that evolution is worthwhile to consider. And I'd like to thank all our speakers today for taking the time and coming to the college and speaking to us. Thank you very much.